Okay, lovely. All right, great. Well, let's get started. Thank you so much. Um, Thank you very much for the lovely introduction. I'm going to be talking about social inclusion as a focus for efforts in the field of global mental health. Just to mention the logos above. So you've been introduced to the University of Edinburgh one and the Addis Ababa University one. We've put together this Global Mental Health Collaborative, which involves people from Edinburgh, but our colleagues in the Global South as well, very interdisciplinary grouping. That's what that's all about. Um, and this slide just is to kind of just introduce a little so you can kind of know where to position me. So I lived in Ethiopia for quite an extended period of time, for 17 years. We just came back to the UK last year, but my work remains in Ethiopia and other countries across Africa. So that's sort of where I've been mostly working. My work is quite linked to policy within country, but also working with the WHO Collaborating Centre in Addis Ababa University, and previously at King's when I was at King's. I just so you kind of know about me really is that the Addis Ababa University has a PhD program in mental health epidemiology. So I was part of getting that set up, and I think sort of this capacity strengthening goes hand in hand with sort of research programs. So it's really just wanted to emphasize that side of things. And David has already mentioned, one of the most things that I think has been a big pleasure to do, which was the book Where There's No Psychiatrist. It's free to download and you can use and adapt the materials in any way you want to. So if anybody has an interest, please take a look. So just to get us started, this is a quote from or a description of one of the farmers who was part of the Butajira project in Ethiopia. The Butajira project's a famous one. The reason I went to Ethiopia was because Ethiopian psychiatrists and public health clinicians were already leading this incredible program of research, community-based, population-based surveys to really get high quality epidemiological data that would be able to inform policy. And so this was, as part of doing that, they also kind of put in some rudimentary mental health services as well. So this is just a description of a person. This is a man who's married, he's got children, and he develops psychosis, and it has the sort of unraveling effect, and he ends up actually becoming homeless, and he ends up suffering the indignity of being restrained because his family has no other options. Goes to traditional healers, they end up selling a lot of their possessions. He comes to the mental health project and he gets medication, but he's still not able to participate fully in society. And so really that's what this is all about. This presentation is trying to think about, well, how could we go beyond just kind of getting people mentally well, and think about those bigger goals. And I am going to be sort of embedding and anchoring what I'm talking about in Ethiopia, which is where I know best because that's where I was for a long time. I did my PhD in Ethiopia, living in Butajira for 2 years, and commuting back to Addis at the weekends, and sometimes being there for extended periods. So just to orientate you, Ethiopia is in the Horn of Africa. It's a large country, populous country, well over 120 million population now. And like many low income countries in that region, it's predominantly young population. Um, it's really, I think one of the points that's really important to make is I'm going to be talking about contexts in this talk. And sometimes people use Africa as a shorthand for some kind of homogenous group, in a way that we wouldn't tolerate for if we said Europe, for example. And just to underline that even within Ethiopia, there's immense diversity of cultures and ethnicities and even languages and dialects. It remains a predominantly rural society, and that So there is rapid industrialization, but not as rapid as the country would probably like. And still, you know, the mainstay of people's livelihoods is farming. And it's stubbornly down in the Human Development Index. Many cultural resources, but on economic terms and in terms of education access. And because of the recent civil war and political unrest, unfortunately, it's kind of been a bit stubbornly down in the bottom. Just a little bit of a very brief context so we know where we're coming from. There's because I said my colleagues in Ethiopia really had this amazing platform of research that I had the privilege to join them and benefit from their mentorship and their you know, their inspiration. So they have done this incredible work, really showing that the burden of most different mental illnesses is at least comparable with those you find across settings in high-income countries. There's not a massive mental health workforce. There's been a big expansion of psychiatry training, but you know, the population is also increasing, and still less than one psychiatrist per million. And the services tend to be centralised in hospitals, and that's where most of the rather meagre budget that's committed to mental health services is concentrated. The population health problems that are kind of taxing the Ministry of Health and really evident within populations are still around communicable diseases, nutritional problems. There's generally low help seeking for mental illness and lots of different reasons for that, really, which will come up in some of the things I'm going to talk about. And family, I mean, around the world, family have a very important role to play. I've put here that family are crucial for care in recognition that somebody cannot come to services unless they are brought. So that is pretty much always the family. And it's a very religious country. It's very unusual for somebody to say they're not religious. So we've just been doing an epidemiological study, and we've got 300 people who've responded so far with psychosis and their families. And the Ethiopia team were really disturbed because 3 people had said they had no religion. So that's extremely noteworthy and unusual. So the Orthodox Christian Church is sort of where a lot of Ethiopian identity has historically come from. And that's still the major religion, but Islam is very big as well. And the Protestant Church, and then there's also traditional healing as well. And that is very much kind of part of everyday life. So people are actually very observant. Again, in our EPI study, we find, you know, most people are going at least once a week to some kind of religious institution, but more people are actually going more than once a week. So it's quite part of the fabric of life. So I'm going to be talking about social inclusion, and it is a little bit of a tricky, slippery concept. But actually, today in World Psychiatry, there's been an excellent article published by Claire Henderson and colleagues about social inclusion, how we can think about it, and how we might want to improve our responses to promote social inclusion for people with severe mental health conditions. So I wrote a response. In World Psychiatry, they often, I'm sure you've seen it, they invite people to write responses. So I've done one around global mental health, which is a lot of the themes in that sort of brief commentary are being picked up in this presentation today. So, but there are lots of other really interesting commentaries as well. So I recommend, if you're interested, to look that up. And then Joy Noel Baumgartner has done a very thoughtful piece about how do we actually conceptualize it? It's a bit of a mess, the way social inclusion has been conceptualized and measured in the global mental health space. And so she sort of reviewed the literature, which is not really in the health literature, it comes from different places. And I think she's a social worker by background. So it talks about it's not just about participating and you know, asking people, how many groups are you part of? Are you part of this? So do you do that? There is something also about belonging, about being accepted, and about choosing. It's about having some agency to decide whether or not to participate, and also capacity. So that relates obviously to when somebody has a severe mental illness, the extent to which the illness is getting in the way of participation as well. And then the opportunities and the barriers for participation. So that's where I'm coming from when I'm talking about social inclusion. And another thing we've been doing recently in our work is sort of trying to think beyond individuals. So I've tried to think about those concepts from social inclusion to put across this socio-ecological model, which thinks about the person as not a sort of individual in isolation, but within a family, within a community, within a broader environment. And you can think of things like agency. You would traditionally think of that as being an individual. Um, but actually, probably in this setting, the family is very important as well. Acceptance, family, community, opportunities and barriers, maybe across all three of those levels. Sense of belonging, capacity, maybe more at the individual level. So what I'm going to do now is come to, so we're talking about social inclusion, is thinking about what is it important that people are included within. So I'm going to now take you through some of the Ethiopia evidence around what we know about might be important, and then relate some of that back to the socio-ecological model. I'm going to kind of, in a way, lay out the problem for you first, and then I'm going to come, the next phase of this presentation will be around where do I think would be the ways to go, or what are the things that we've been trying and testing and evaluating in the Ethiopian context to try and kind of overcome some of these barriers. So work by Laura Asher and Wabalan Fakadu, pictured here, trying to understand what it means to people to get well from severe mental illness. And there's this term, restoring the person's life, that was used by some of our stakeholders. And very much what was prized are things that really overlap with the concept of social inclusion. So being able to work, being able to recover economically were very prominent, but also these socially important things about being socially important, being socially valued, having, you know, the same social value as other people and a role, being able to fulfill adult roles, treated like other people, as well as value given to having, you know, alleviation of symptoms is also important. This is my colleague, Dr. Eshetu Germa, who very sadly passed away recently, very suddenly. He was a real champion of mental health stigma research in Ethiopia, and he did a nice review about all of the evidence we have from Ethiopia on this topic, and then some nice qualitative research. And this again highlighted, you know, stigma happens at that kind of interface with what matters most to people in life. That's where attitudes become kind of sharpened. And so in the Ethiopian setting, the important, again, this is reinforcing what I've just said in the previous slide, that being able to contribute to expected social activities is really important. These kind of, and these are not sort of social in the sense of I'm going to a party, this is a leisure thing, it's fun for me. This is more about mutuality, that the expected social functions that somebody has to do within a kind of close-knit rural society. Being able to complete school, being able to find a job, make a living, fulfill family responsibilities, you know, sort of be able to kind of shape up to what's expected of you. And then this kind of being able to be free within social interactions. And a lot of research from Ethiopia has been done, really helpful research that has really been very helpful for us in terms of policy advocacy. So you can see on the left-hand side, there's a lot of research that show that stigma and discrimination is, you know, really one of the things that is leading to people being excluded in a social way. So functioning is not just about the person's capacity, their mental health problems, but also there's a lot, most of the functional impairment that people are experiencing is really from the outside environment that is excluding them, not allowing them to do the things that they would like to do, to work freely, to work collaboratively. You can see the picture here, farming. It's rare to see one person, or you've got two ox families will rarely have both oxen, so they have to kind of share to work together. And if you're being excluded, you're excluded from that economic opportunity or that necessity of farming. We found that for food insecurity, discrimination is a really strong predictor. That exclusion can be internalized with it, and self stigma, and that has this kind of interacting impact on how the person engages with treatment, and that itself is going to be feeding into the extent to which they can become well, and that again is going to affect the level of outside stigma that is experienced as well. And then lots and lots of quotes and people talking about their stories, experiences of being deliberately excluded, even when they recover, even when they feel well. The taint of mental illness means that they're not felt to be reliable people who you can have in leadership positions. On the right-hand side, this quote sort of just gives you a sense of how social inclusion is not just about sort of it goes towards economic impacts as well. This idea that you're not allowed, people won't work with you, and that's very important in a subsistence farming situation. But I talked about that family layer as well, and that's not a layer we often think about, but it is so much determining the experience of a person with severe mental illness in the setting where I've been working. Sally Soraya did some beautiful work trying to work out who makes the decisions about treatment, about care, about what happens to the person, and that's very much the family or people within the family, or actually sometimes community members, but predominantly it's the family making those decisions. Desalin Kiros is one of our students who's done this beautiful ethnography around family life. So hanging out with people with severe mental illness, seeing how they're included and excluded within the routines of a family life. And so often kind of not felt to be full members of the family, not given the opportunity to contribute, and therefore sort of feeling really kind of excluded. But then families themselves, just by having a member who has a severe mental illness, also experience their own exclusion, which also means that poverty is happening at the household level, not just at the individual level. So these, I'm trying to kind of get you to thinking of some of these different levels through which people with severe mental illness are being kind of hampered from social inclusion. This is the PRIME study data. I'll mention a bit to you later, but this was a community sample, so fairly large, and it just gives you some kind of attitudinal data, if you like. So those were qualitative studies I've been showing you, but just to show that sometimes that perhaps the legacy of the WHO multi-country studies on psychosis, and this idea that it appears in those studies, it appeared that people with schizophrenia had a better outcome, and there was lots of kind of hypothesizing it was because of more accepting communities. So the Ethiopia Butejura study very much showed, when they followed people up, that they very much didn't have very healthy and good outcomes. And you can see here that stigma, unfortunately, is alive and well in this setting. So, for example, people should generally be caring and sympathetic is only 59% of the population. And then this concept of structural stigma, which is where sort of, in institutions and things, it becomes baked into the way things that are done. So you can't really sort of point the finger at an individual. And this is often doesn't feel like stigma, but its effects are to be sort of unfairness, kind of being infiltrated through all the different sort of systems. And we did a sort of study about the response, the mental health service response in COVID. And there was really clear evidence of structural stigma, where very scarce mental health services were diverted immediately they were closed down hospital and just made it available for COVID. Whereas you have general hospitals where the same functions are repeated in many different places, and you could easily kind of absorb in other bits of the system, they were kind of protected. And people who had severe mental illness who developed COVID really struggled to get vaccines well, as a population, they weren't initially on the kind of high priority for vaccines and things like this as well. And this is kind of helping to conspire against people getting well in the same way that they would from a physical health problem. So just going back to that conceptualization from the socio-ecological model, and just sort of unpacking that a bit, you can see I've just put on the kind of evidence from Ethiopia. And what I'm partly going to be saying to you is that actually a lot of the time as psychiatrists, as clinicians, we think about the individual, we think about symptoms, we may think about functioning, but actually, we and of course that guides our intervention. But so let's look at agency. So the agency is mostly not the person in this setting, it's the family that decides, but also because of the accumulative effects of stigma, you have this kind of disempowerment where even if you ask the person with psychosis or severe mental illness what they would like, they might well say, and this is what has happened in our studies, that you know best, you're the expert. So it's undermined through these external forces. Capacity, again, we might say, well, not everybody responds to antipsychotic medications. So that's true. So there is something about the severity of the illness and its response to simple antipsychotic medications. But then it's also about, well, what medications are available? They're very sedating. It's very difficult for people who are subsistence farmers to be taking a sedating medication. So then it becomes more about the health system, actually, and what is available, and reliable supplies of medication become very important as well when we're thinking about adequate responses to treatment. Poor self-management is kind of linking in with agency, again, with that disempowerment. And because physical health gets overshadowed and neglected, that kind of fuels poor outcomes as well. Sorry, we've lost the animation. So I'm now on acceptance. So in terms of acceptance, that's more straightforward to sort of think of that in terms of being something outside of the individual. So that's a property of is how accepting is the family of the person and the community. In terms of belonging, that's the perception of the person, but clearly is going to be very much affected by the experiences that they are having. And in terms of the opportunities that people have that could be, and the flip side of that, the barriers to social inclusion, I've talked relentlessly to you about stigma, but access to care, poverty, livelihood opportunities, all of these are kind of consequences, but also reinforcers of exclusion as well. So what has global mental health been up to in trying to think about, this, what I think probably I don't need to convince you is a problem. So it's very much been a focus from the beginning was on something called a treatment gap, which is a population level metric, sort of balancing, well, how many people do we think there are in this population who would have a need for biomedical treatment? And then what proportion of those are actually accessing? And what we've sort of found is that there's a really huge treatment gap, even for severe mental health conditions, which are very evident and prominent. So, most communities would say, yes, there is this problem. They may not call it a severe mental health problem. This 90% treatment gap, though, kind of belies something because this could be like a once in a lifetime and it doesn't tell us much about adequacy. And underneath this treatment gap, you can see what's kind of fueling it. And on the left-hand side, these boxes are really kind of supply side issues. So these are really prominent. The lack of kind of policies, plans, and governmental commitment of funding, the centralisation, the lack of specialists. But then you've also got these kind of these demand side problems as well that are going to be important as well. So lacking information about mental health treatments, the availability of care, people's rights, lack of awareness of that, and preferences for other approaches, of course, is really prominent. This paper is sort of anchored in Ethiopia data and tries to think about that gap a little bit more in terms of what matters most to people. So really the treatment gap is referring to this sort of lifetime access gap, which is, if you like, the smallest of the gaps. Then if you say, well, how many people who are ill are currently accessing, that's a bigger gap. And then what about the adequacy of the care, which is kind of linked to the quality of the care as well, the next one up. And then, to what extent is it actually able to be effective? And then this big gap, which is the one I'm really focusing on now, which is, and then to what extent does treatment and intervention achieve what is actually valued by people and what will make a difference to their lives? And then, we're really talking about quite a different thing. Okay, so that's all the negative. What I'm going to talk about now is, well, then where would we start, and what things might be helpful, and how can we start to think about what pathways there could be to enable more social inclusion. So the first thing is we've done a lot of work, as David said in the introduction, about how to increase access to mental health care, largely through integrating into primary health care, which is much more accessible, closer to the community, and is also, I think, sometimes it's framed as task sharing. We also, like to say it's actually about integration and ensuring parity of physical and mental health care. That in a sense it's not task sharing. This is the task that should be for any health worker, is to deliver mental health care alongside physical health care. So a lot of our work has been trying to make that into a reality. So this is our community advisory board from Sodo district in Ethiopia. And at the bottom, you can see the three leads: Chris Lund, Mark Tomlinson, Vikram Patel for the Prime study, and Ababao Fikadu, who's the Ethiopia lead. And what we worked in this district, the Sodo district, which is really quite a rural district, even more rural than the general population. 180,000 people in this district at the time. And there are no doctors within primary care, 8 primary care centres, no mental health specialists at all. So the nearest mental health specialist was a psychiatric nurse in the neighbouring district, about sort of 30 to 50 kilometres away. And low literacy across the population, and lots of kind of problems with communicable diseases, and quite difficult terrain. You can sort of get a sense of that from the picture. And we did this kind of participatory processes, working a lot with the local health administration and different stakeholders, including police, the kind of women and social affairs, actually education, and caregivers. And then over time, we were able to include people lived experience of mental illness as well. And it looks very complicated because this is really a programme of care. So it wasn't just about training primary care workers in mental health care delivery, which is, so on the right-hand side, this is the WHO's evidence-based guidance training package for primary care or general healthcare workers in mental health, sort of first-line mental health treatment. So you can see, if you go row by row, at the bottom we have the community. So as part of a program, you need to also make sure the community is aware of the program, to proactively do outreach to identify people who may benefit and link them with care. At the primary care, you've got the sort of the identification of people, initiating treatment, and then following people up. Specialists are psychiatric nurses who are sort of being kind of consulted with about more complex cases, helping with review and doing supervision. And then we have the kind of system level things, so making sure the administration is understanding how to program mental health care, getting supply chains set up, trying to facilitate some multi-sectoral links, and just supporting program management. So, this was a big undertaking. And just when we say integrated mental health in primary care, it's not just about hit and run training. So what impacts did this have? We evaluated it through, we did this proactive case detection of people with severe mental illness in the community. We identified 369 people with probable severe mental health conditions like schizophrenia, bipolar disorder. And when the people doing the proactive case detection were community health workers, and they had very brief training on sort of pattern recognition, sort of vignettes of kind of common presentations. And we had very high uptake of care initially. So 81% did engage initially with treatment. We also looked at the accuracy of primary care workers just to make sure that, obviously there are potential harms with this approach as well. And you can see that they were pretty good for a kind of diagnosis of severe mental illness psychosis. And then we had this cohort of 300 people with severe mental health problems and 300 matched kind of households. That there were many benefits for people who had quite chronic illness at baseline. So suicidality went down. The most modest effect was actually on symptoms, and this I think is starting to speak to the social inclusion part of things. So even though we weren't really having very much, it was a statistically significant improvement, but not clinically. But we did have a moderate impact on functioning, abuse, restraints reduced down. So at baseline, 25% of the 300 people had been restrained in the home in the preceding 12 months because of severity of illness, the family feeling that the person would run away, would get into harms, would be vulnerable. And that went down 50%. And there was a significant reduction in discrimination as well. But we also found that food insecurity went down, and we're really just providing mental health care. There's no cash transfer or anything like that. But we did find that relationship between providing treatment and achieving an improvement in food insecurity was mediated by a reduction in discrimination. So I think this is showing us that treatment has a role in promoting social inclusion. It may not be enough, but it may be potentially necessary, but not sufficient. We looked at this qualitatively as well. And I think you can, this quote, I won't read it out, but it's sort of talking about how maybe the community had written off some people who really had an idea about what it meant when you got mentally ill. But seeing a few people recover, especially people that were quite prominently unwell, really sort of unlocked a lot of community mobilization. So the community had kind of had the sense, well, what's the point? And given up on people. So I think medication can catalyze other changes from the community. So on the left side, you can see we did a lot of qualitative interviews, and you can see from the themes that medication and treatment was valued, but it was also felt not to be enough. And people emphasised the importance of regaining livelihoods, and that the thing that had been least improved was around inclusion. Here's a couple of examples. So yeah, you can see that the kind of social status of people may not be restored even if they are well, or their symptoms improve. And also the losses, the financial losses incurred, mean it's quite difficult for people to regain their standing. And if you're very poor, it's very difficult to enter into those reciprocal relationships within community life. And then there was also evidence, this is a social distance scale looking at stigma attitudes from health workers. And you've got the pre and the post, them being trained and supervised to deliver mental health care. And you can see there's very little change. So that, health worker attitudes are quite stigmatizing. So I've shown you that providing a sort of integrated mental health care program can have definite benefits, but there are limitations. And so the things we've been working on in terms of in terms of health services, current work is trying to think, well, how can we engage people better? And not, we had a lot of early engagement, but we had a lot of people dropping out of care. And only 30% had what we consider minimally adequate treatment over a 12-month follow-up period. So the focus now is, well, how can we sort of do more sort of person-centered continuing care, which doesn't really fit with the existing health system, which is very kind of short, brief episodes of acute infectious conditions, moving towards more recovery focused and more proactive physical health care. So that's where we're working now. And then also we've been doing some work about reducing stigma in healthcare workers. And this work by Brandon Court and colleagues has actually shown that if you reduce stigma in healthcare workers, their mental health competencies, the extent to which their skills in mental health improve as well. So that's one thing, thinking about what you can do within a health system and through mental health treatment. But, it's not enough. So the second thing that we've been doing a lot of work on is around harnessing lived experience. And this sort of idea of social contact has been really important. So there was the Lancet Commission on reducing stigma and discrimination in mental health. And this was really one of the biggest and most effective strategies alongside providing information. So it's basically a person, I'm sure you know this, who's had a mental illness, has experienced some level of recovery, and is supported and equipped and trained to be able to provide a testimony in a public sort of setting. And the social contact is having this connection so that people start to see the individual as a kind of human being. They have developed empathy, and it can really break down barriers. And we found that this has really helped to sort of catalyze kind of empowerment as well. And you can see from some of the quotes, so kind of giving people strength to go forward and this confidence to speak and provide their story as in itself has been beneficial. So we've used that kind of training in how to deliver your story and think about recovery using kind of different methods, some of the photo voice and empowerment training here. And then, so this is an example of photo voice where the person uses these photographs as kind of anchors for their testimony. So they start with something symbolic of when they were unwell, when things, when they're being treated badly. This is the kind of restraint, the wooden bars where the woman was restrained. You've got a picture here of everybody who's worked in Africa will know this is chlorpromazine. And then the next picture is somebody kind of actively sort of engaged in cultivating something within their kind of patch of land. And the photographs kind of help to just provide a different way for people to engage with the story. And we've used that in sort of some participatory action research, where people with lived experience start to kind of prioritize the things that they think are important, work together, and then start implementing to see the extent to which they can achieve change. And just through this very small project, for example, in a very rural area, they managed to kind of mobilize the district administration who gave them, some space to be able to, and supported them to set up a service user association at a very rural area, which was not an intended thing. And I guess with participatory action research, you don't know what the outcome's going to be, but it went much further than we imagined it could. And these quotes just give you a sense that actually just that process of being involved in something, people talk about the value people give me. I'm not hidden or neglected. I'm free. I'm not a person, I have been this person discriminated and neglected, and now people start appreciating the improvements I've observed in myself. Yeah. So really supporting social inclusion in itself, as well as potentially unlocking and helping to overcome some of those structural barriers. And we've started kind of working with our lived experience association in Ethiopia to use this approach so we started off using it with primary care workers and community leaders. And now everything we do, literally every training we do, we integrate social contact. And it always kind of brings the training to life, and helps to kind of shift the mood and really kind of sort of galvanizes some motivation within people. And on the right hand side, this is the work we're in process. So we're using this around the spaces of kind of traditional and faith healers, very important for people's lives, and often, a source of exclusion. Police, that's around pathways to care, journalists, the way they present people and talk about them, and then higher education as well. And the other kind of harnessing of lived experience is around peer support. So um, people who are experts by experience, sort of having a relational kind of interaction with people who are earlier in a recovery journey, and sort of supporting them to think about, what they want from their care and helping them to get the information they need, supporting self-management, and helping to promote those kind of more sort of being a bridge really to broader society. And there's been a recent randomized controlled trial published just last year from Uganda. Well, Uganda was the Africa site. There was a multi-site trial called Upsides, and they did show some beneficial impacts on social inclusion. We're using this approach in our homelessness project. This is Hope, and we're working in Ethiopia, Ghana, and Kenya. This is our lived experience advisory group who are integrally involved in everything we do in the project, and are a great source of energy driving things forward. And so they've been trained in peer support, and then we're adapting to try and extend it for people who are also homeless to kind of support other people. We did some ethnography. We found this was somewhat happening spontaneously anyway. And so this is kind of giving it something of a framework around that and more of a recovery orientation. And then the third, treatment sort of and kind of formal services, which that's a kind of comfortable space. Harnessing lived experience is a bit more sort of out there, perhaps. And then third bit is really to think about those structural barriers and the extent to which social resources can be mobilized. And I've kind of repeatedly said that poverty has this sort of two-way relationship with social inclusion. And rather trying to kind of go through other pathways, should we just be trying to kind of alleviate poverty, thinking about cash transfers, disability benefits, so that people who've lost a lot during kind of lots of expensive help seeking, and the impacts of not being able to work and their family not being able to work, they have to sell assets. Can they be brought back to an even keel? And that would be kind of a platform for inclusion. Most low-income countries don't have disability benefits. Most middle-income countries do. It seems to be one of the distinguishing things. So it's a big thing to kind of advocate for. And then at the family level, as I said, we've done some work around what happens in families. Um, this slide would have been better with animation. I do apologise. So we've got on the left-hand side, I've just wanted to illustrate to you that we've tried to really understand what goes on in families from reviews and even from, we developed a new family communication and involvement scale to understand from the perspective of the person with psychosis the extent to which they're involved in family life. And we're using that to kind of develop an intervention that has one of its goals around the extent to which the person can be involved in day-to-day life within the family. So we've got our sessions sketched out and we're going to be moving towards piloting by the summertime. And then another big bit of work is around engagement with holy water sites and different healing modalities and trying to kind of develop collaborative ways of working. Now, this can often, when you start with this sort of work, it ends up that we start to say, well, yes, we're going to engage with religious leaders and we're going to teach them so that they'll be able to identify people with psychosis early, refer them to us so they can get proper treatment. And so it's taken quite a while to get to a more of a sort of reciprocal relationship where we really recognise that recovery and inclusion it requires it's something that a mental health service cannot give, but this is something that can happen within these spaces. So that's an ongoing piece of work, and this is up in the hills in Ethiopia. And just the last thing is really, I've sort of been highlighting these different levels and things that we know and things that we've measured, but there's really, we don't really know how they all link up and what are the key leverage points and, is it all about the money? If we solve the poverty bit, maybe some of the other bits of the social inclusion would just fall into place without needing a kind of stigma campaign or something like that. Maybe there are some things that could be more important and be more impactful. Maybe it's the empowerment piece around the peer support that can drive lots of different levels. So that just requires a lot more research. And yeah, this was just to remind you of the kind of different ways that these pathways may work and potentially different, of course, for different people. And lastly, just to say, well, then, how would you think about intervening? Obviously, understanding those mechanisms would be good. And we've just done another very big review that's just out in preprint. And we looked at all psychosocial interventions for people with psychosis in low and middle income countries. And only 16 of them measured social inclusion as an outcome. And only most of them were directed at the individual. They didn't think about the individual and the family or the community, and they didn't think of the person in those kind of broader contexts. So there's a really big gap in the evidence base about how best to respond. So just to summarise, I think these pictures sort of show you, about, well, what is inclusion? It's, being part of things, participating in things that you want to participate, that you value. But these are more than just sort of sitting around having coffee. These are kind of economic relationships. These are supports in hard times. Just very important. And if I go, the last slide is just to say that, social inclusion is not just sort of enjoyment. It's a necessary thing for survival in this context. I think I've shown you that treatment is likely to be a catalyst to inclusion and to help some of the social capital that exists in many Ethiopian communities to kind of kick into being. Thinking about the person beyond just the individual, I think, is really helpful just for thinking about social inclusion outcomes and the mechanisms, but also where we might want to intervene. And then we really need to think contextually and recognise that, what social inclusion means in one setting will be different from another. And I do, with my feet in Edinburgh and in the access practice, working with this population that are homeless, and also, experience lots of sort of exclusions. I can really see that there are some areas where our more community focused work in Ethiopia, there potentially could be some really important things to learn and to see if we could bring back to this setting as well. So that's the end. I just want to, so it's my life in logos, all of our projects. Many people to thank, of course. So I'm not going to list, not going to read them out, but a huge team of people working on this. And just to thank you for your interest and your time.
Oh, and thank you, Charlotte. That was wonderful. A very inspiring presentation, actually. A good for morale for people who work in mental health type presentation, actually, which is nice. In spite of the fact that obviously it starts with an awful the size of the challenge is huge. But we've got some time for questions, if that's okay.
Yeah.
Um, so if people want to put their hand up, either physically or electronically. Um, oh, Ian, you've got.
Would I be Chris there?
Oh,
Thanks. Can you hear me? Okay. Yeah, yeah. Thanks for such a rich talk. Being at the end of my psychiatric career and having learned things many years ago to pass my MRC psych exam in 1988, I think it was, or 87. Um, Learned about things like the international pilot study in schizophrenia. And one of the things that we were told were that in what presumably were low and middle income countries then, I think maybe India, the Indian subcontinent, that the outcome for schizophrenia beyond the acute phase was often a lot better compared to Western industrialized society, that the person was more likely to be back with their extended family, more likely to be reintegrated in society. Now, I wonder if that was just a wild generalization from that study, or whether, hearing what you've told us about Ethiopia. I mean, I imagine it's so variable, but so it's would that still hold true? One wonders. And the other, I often think, what's going on in a country's mental health system? Is there a big old-fashioned mental hospital where people are being restrained and locked away? I mean, one of the shocks recently from the Russian-Ukrainian war was to discover that such awful institutions were there, neglected people in a Ukrainian mental hospital. Some probably with intellectual disability, but some with psychosis. And, so it's what's really going on. Well, go and look at the big old hospital that might be lurking in the background. Anyway, there's kind of two questions in there, but no, thanks for the talk. Yeah, yeah.
Yeah, thank you very much. Yeah, so those WHO studies have, there have been some quite robust critiques of those. I don't think they're, I mean, I think they're really important studies. And I think you're right that it's quite difficult to sort of really generalize. But I think one of the big critiques was um, when they talk about good outcome, they do it in relation to the people who survived. But actually, there's a really high mortality. Um, Another thing is that some of the indicators of outcome have to be considered in relation to the background population. So, for example, rates of marriage may be high, much higher than you would think for somebody with schizophrenia in our setting. But if rates in the general population are also very high, then it's not just about being married, it's about what does that mean. We also we did some follow up and looked at the number of people who were sort of reported being involved in farming, and it was 70% or something around that level, which is high. However, when we asked them and the extent to which they felt they were able to adequately work, it was much, much smaller, and it was much closer to the kind of effective work that you would imagine. So I think it's partly a problem of measures, partly a problem of following people up and getting the right. So I think it is slightly romanticized. And I think, for example, our ethnography of families have shown you can be with a family, but you can be kind of isolated and excluded and within your family, even though they're looking after you, they're feeding you. But so I think it is just a bit more complex kind of picture. And then your second question about institutions is so I do some work with WHO on sort of deinstitutionalization. It's really a really important and yeah, very motivating piece of work. But Ethiopia doesn't really have enough institutions, actually. So we only have one big psych hospital with around 250 beds. And so where are people with severe mental illness? You know, most of the restraint is happening in families and in holy water sites. These are the kind of de facto institutions. And then more recently, we've seen this kind of explosion of these sort of social care institutions, these kind of for the destitute sort of warehouses, with very sort of impoverished kind of living experiences and quite susceptible to abuses and not very safe. So yeah, it's so institutions are bad, but if you don't have some place where people can have acute care, then you know people go to other places, they end up in prison, they end up a lot of them homeless as well. So yeah, I think it was Graham Thornycroft who talked about sort of balanced care, didn't he? And I think many African countries it's don't have the institutions. I think in North Africa, I know Egypt has massive institutions, so it's a little bit depends on some of its colonial legacy and sort of you know where history has taken you. Is
Thank you. Thank you.
that Chris? No.
Muted. Yes, Chris, could you answer?
I'm a Signalo. Is that correct?
Oh, but I'm on the second Alu.
That's all I recall.
Very good.
So
Very good.
my question hinges on some assumptions that may be misunderstood, so you might want to challenge the kind of setup of the question. So um, my kind of understanding is that there's a sort of a transcultural psychiatry perspective and a more global mental health perspective. So the transcultural psychiatry being more anthropologically led, people like Lawrence Kermeyer, and that there have been some criticisms of kind of the traditional public health approaches, perhaps, and I'm thinking back when I was interested, so 10 years ago.
Yeah.
And it sounds like there has been a shift to recognizing those kind of wider structural issues, and obviously that was the topic of your talk today. And I just wondered, assuming I've set that question up remotely fairly, is there a kind of a reciprocal dialogue between people who may have been a little bit more cautious or a little bit more critical of those kind of global public health initiatives in the first instance? I hope that makes some kind of sense.
Yeah, it does. It does. And I think so I think global mental health is a very broad church these days. And I mean, for example, we came together to do some kind of article for Lancet Psychiatry on responses to COVID. And part of it was kind of understanding what sort of responses there were. And there was, you know, it wasn't just happening with big kind of research teams from the West with psychiatrists at the lead kind of implementing, and there's very many kind of community-based initiatives, and you know it's just the sorts of things people are doing now are really diverse. So I think it has, and if you compare it to many global health disciplines, I really think that there's been, I think it was a fair criticism, and I think there's been a kind of a can we relax? We want to rally around the treatment gap. That was the kind of really important thing, I think, at the beginning. It was a very simple message coming from nowhere. I think it helped to get global mental health on the agenda. But I think people, even the people involved in that, are not hardcore sort of psychiatric people. I mean, you see what Vikram Patel is presenting on now. He doesn't always believe any psychotropic medication sometimes. But I mean, yeah, I think so. It wasn't, but there has been a bit of a recalibration, I think. So for us, we've started doing much more ethnography. I've highlighted that, and it's partly that, we've developed the PhD program, we've developed more mental health researchers, we've been able to broaden out sort of interdisciplinary links and build that. And the ethnography has been so illuminating. And the Global Mental Health Collaborative in Edinburgh is really, the biggest contingent is anthropology, social work, ethics, and medical sociology. And psychiatry is just a sprinkling. So that's, I think, very positive. And different people are kind of working out, there are different languages spoken in those disciplines. And those alliances, have to be kind of worked out. And there are dangers, I think, going too far either way. So I'll try to keep being middle of the road.
Totally agree, and that's very helpful. Thank you.
Thank you. Gordon.
Nodding to what Ian said about better outcomes, and just a very open and a vague and also a very open question. What do you think, if we look, from your understanding of what happens with mental health in Ethiopia, might we have to learn over here in terms of the challenges that we face over here?
So I do think, so some of the things, it is inescapable that social capital is high in Ethiopia. Communities are tightly knit, and it's not something you can just easily reinstitute in Scotland. I really miss it living here. I'm like, where is everybody? I sit in my house and nobody just comes and knocks on the door and comes round all the time, which is kind of really annoying at the beginning when and then now I feel like, where is everybody? I'm just sitting in my house on my own. So I don't know. That's a very cultural change. I mean, I think it's not culture. I think culturally that was potentially present much more in the UK, and I don't know how you kind of mobilize those community connections. I know. So, for example, some of the stories in Prime were really remarkable. Once we started providing care, there were some homeless people in this rural district, and we didn't ask people to do this, but community members took these people in because they could see that they were responding to treatment and helped them to get reunited with their family, or somebody paid for their rent. And I think there's a lot of commitment to people that are not your family. And I don't think there's a magic wand that you could sort of make that into an intervention and bring it to Edinburgh. I think there has been much more of a willingness to work on the peer support. And I think that I know that it's definitely, it's obviously integral to, there's an NHS, there's a UK-wide plans on peer support in mental health. But I think it's just been very well received in Ethiopia, which surprised us. I think, so I think it's around the social side where I think we could think about how could you catalyze more social glue, really.
Am I allowed to respond to that very briefly, David?
Yeah.
Yes.
I mean, I think we can't change society, but we can certainly change the way that psychiatry uses those social links. And there's something radical. I think it's called relational psychiatry. My goodness, we think functionally, we think systemically, and I think it's one of the biggest research projects. I can't remember his name. One of the candidates for the presidency of the college is doing a 2 million 5 centers where he's using, I think it's called relational psychiatry. There's a lot of work done in Finland, where it's really systemic, and that shouldn't be radical. And so I think that's not trying to change society, but it's trying to change the way psychiatrists we use that and focus on that. And the fact that that's so radical in the UK, I think really points to there being a lot of work to do in that way. So I think that's very interesting what you're saying, and I think we can use that. We can't. How do you bring it to Edinburgh? Well, we bring that different mindset to Edinburgh and
Yes,
see
yeah,
how we can use that. And I think that search is wonderful that's been done in terms of relational psychiatry. The fact we can even use that term is pointing towards a need for something. But thank you. Wonderful, rich talk and very interesting. Thank you.
thank you very much, and that's really interesting. I'll have a look at that. Thank you.
I think it's Russell Razak, is that his name?
Russell Razak, that's right.
Who was
Russell
actually
Razak,
an earlier contributor to this esteemed
yeah.
speculative psychiatry group.
I'll share a link in the chat.
Right.
Open dialogue is the.
But he didn't get the
Oh, the open dialogue. Yes.
yes,
Yeah.
that's the finish.
Open dialogue, yeah. I think it's
Yeah.
also called relational psychiatry sometimes
That's
as well.
his.
But
That was his.
open
That's the
dialogue,
thing.
yeah. Very interesting. And just trying to replicate within the psychiatric setting some of what happens more naturally in other cultures, I think.
And I think maybe, I mean, social interventions, like, I mean, there's things like Clubhouse that they've kind of died. These sort of trying to construct places and spaces. I know there are recovery colleges. Those have not really taken off in sort of sub-Saharan Africa, but they might do. I know they're in Uganda. I think, yeah, ways that there have been many effects. I mean, I know from being in community mental health, sort of giving people access to adult education, to gyms and stuff, but helping people to feel that they belong is I think maybe the higher standard, isn't it, that we want to try and get to. Oh, thank you.
Well, okay. Is any Caesar?
Oh, Caesar, you're mute.
You're muted.
Thank you very much for the lecture. We can learn a lot from other countries, as I worked in Palestine for many years. But I'm interested very much when you use words like recovery, social inclusion, psychosis, and those are not labels, neutrality. They were created in English-speaking systems, and sometimes when you move it to other language, when you translate it, not only vocabulary to Amharic or other in Ethiopia, it might give another meaning for it and it could change. So it could change also what really matters for people and how they see. And another thing is the manifestation of these things could be sometimes inside the culture. Not individually. Sometimes you see behavior in the culture, and like mental health in more middle income countries could look like culture, but it's not culture. Are you familiar, is it things that you take into consideration in the measurements and these things that?
Thank you. Yeah, highly pertinent question. So, the slide I had about those sort of exploring around recovery, we didn't use the word recovery at all, because it's, it has such a connotation, and also we thought it was problematic to start with. I mean, the whole idea of personal recovery, thinking about which, and the domains of personal recovery, including sort of these self-actualization kind of goals. And so we've done a piece of work on that and looked at existing recovery measures, and with a lived experience group, and with that sort of rich qualitative work. And as you would expect, people that they don't make any sense to people, that and it's all about a social recovery. So we've developed a new measure called the Reconnect that we're using, and we did a validation. We haven't looked at it longitudinally, but that was developed with Ethiopian colleagues. I think there's been a couple of sort of reflective pieces around recovery, personal recovery, just being quite Western autonomous, kind of around the pursuit of happiness rather than the pursuit of kind of value in different relationships. What you can, like I said, one of the things the qualitative about what it means to be a functional person, yeah, in a society was like that I can give to other people. This feeling that of not wanting to just be the recipient, and this how important it is to be able to take those kind of roles for dignity. So yes, we've tried to pay attention. For inclusion, I think I was problematizing it, and we don't have a good measure. And there's been a very big criticism of how you measure it. So I did a bit of reflecting on how you might measure it in that response to the paper that was just published today. So I've got some ideas in there, especially around the structural kind of measurements, about sort of meaningful inclusion. But I think it's where context would be really critical. What is important inclusion, and the whole agency thing. Maybe agency is important at the family level, and that we don't want to get rid of that, and people don't want to get rid of that. I think in my PhD, I had an empowerment scale. I was looking at women's mental health, and I wanted to look at and see if they were empowered, did they have poor, better mental health, and I found completely the opposite relationship. Yeah, that the more empowered they were, the worse their mental health. So don't start thinking, oh, those feminist women, that's why. It's because but the questions were around autonomy, the empowerment, and so do you have to ask your husband to pay, to buy this? Do you have to pay? And basically it was saying if you didn't ask your husband, it's because your husband wasn't providing the role he has to play in society, and it means there's nobody looking after you. And I think that sense of family and agency will be much more complicated, and we wouldn't want to measure it with a kind of an individualized agency measure. And we've got a really skilled PhD student from Malawi called Action Amos, who's looking at decision making and agency in the Malawian context. And he's just done a review, and it seems he did a review and then he had to update it, because it got out of date during the review process. And the number of new papers in the last year, it just shows that people are starting to think about this. But really, really critical that we don't just import kind of very narrowly individually focused things. And perhaps my last slide that was sort of showing that review that said all of the interventions we're developing are very individually focused. I mean, that's another kind of reflection of this problem. WHO has just started working on family interventions. The MHGAP has only just put family interventions in, even though the body of evidence for family interventions for severe mental illness is really strong. But it doesn't really sit with what people think about.
Thank you.
No, thank you. Thank you.
We had a bit of a late kickoff, so we've gone over our normal time, but we're approaching past, so we'll wrap things up in a moment. But are there any last questions that people want to, or comments? What you've just said there, Charlotte, is very interesting, because I think it goes to the heart of a question which I'm interested in, about how the whole idea of mental illness is constructed, and where what we might call strong values sit in the actual construction of the idea of mental ill health. And anyhow, that's another talk. That's actually something like that happened. I did one of these a few times ago, but you've given a very inspiring, as I said, good for morale talk. So thanks for lifting my spirits anyway, what you're up to. And I'll just mention the Scotland Malawi Mental Health Education Project, which is my can of worms, and we've just got £200,000 from the Scottish Government to continue the work.
Nice.
I was going to ask you if they've got 60 seconds just to say what you think about the aid budget issues, and it's gone down the pan apart from in Scotland at this point.
Yeah, it's depressing. Yeah, it is depressing. I think there are some opportunities, obviously, and it was a bit neo-colonial, and there's, countries are potentially seizing the opportunity. But I think there are maybe more risks of losing it. And it's just that lack of solidarity, I think is, I think it impoverishes all of us, honestly, that we're not able to engage in that kind of links with people. And we could have done it better. And I think there was a need for overhaul of the way that a lot of the funding was done, but much of it was done really rigorously. And we've had grants from DFID, UK Aid. They were very thoughtful and very careful about sort of reviewing what we did and gave, had proper reviews. And I thought, it felt as if it was a really responsible way that they considered the money. I know that it's not always the case like that, and sometimes it's used in different ways. But so now there's the risk, there's a lot of looking at, it is important to respect countries and autonomy. So I think the Wellcome's just done a big review about how countries can be, set their own agendas, and it will be sort of leveraging governments. And much is good about that. It's just that different agendas start to come in, and sometimes mental health is one of the things that might drop off, because that's sometimes we've had to. It's not necessarily spontaneously what a government's going to ask for. It's the sort of thing we have to engage and negotiate and build up a relationship and nag and kind of just advocate and advocate. And so I think there's a concern there. So, but we're very embedded within the countries we work, so we will still advocate strongly from bottom up, if you like. It's a shame.
It is. But thank you very much for raising the profile of this work, and
Thank you so
for
much.
coming